malaria that you see in at home, or you have some patient. We are talking malaria that comes to the ICU. You understand? So if I ask you a few things, like what comes to your mind if severe malaria comes to the ICU? So what comes to your mind? So if I would yeah. So if I would ask you, what comes to your mind when a patient comes with malaria? So you have a patient who will always come with a diagnosis usually. Patient will have a diagnosis in ICU. They will already have a diagnosis that is malaria. Okay. So what comes in your mind? Some 3 points.
Thrombocytopenia.
Okay. Thrombocytopenia. Then
Altered mental status.
Okay.
Convergence.
So these are the 3 things that come to your mind. Culture, what comes to your mind?
History of high-grade fever with chills.
You have a clinical feature basically. You say you have a clinical feature, right? So what do you say? High-grade fever with chills.
Thrombocytopenia, bleeding and multi-organ.
Thrombocytopenia and
Thrombocytopenia, bleeding and multi-organ.
Anybody else? Chandri, what comes to your mind?
All these points are there, and it can also lead to acute renal injury.
Acute renal disease. So you're talking about acute renal disease. And? Anemia. And? What do you think? What's your name? Sneha. What do you feel comes to your mind? So, I mean,
Hypoglycemia.
what's not coming to your mind, I feel, is the rapidity with which you should treat. Okay, if I look at all these, what should come to your mind is the rapidity with which I'm going to treat this patient. Are you understanding? So, I understand these problems that I'm going to do, but these are all very non-specific. This is occur with any sepsis case. Very non-specific occur in every sepsis case. So what's more important for you to understand is how quickly I have to treat malaria. That comes to the pattern that he discussed as to why it should be quick. Why should it be quick? Why do you feel earlier it should be quick? So what about the life cycle? What is so interesting about the life cycle that makes you feel it should be quick compared to any bacterial infection that you otherwise have? So it's a complete cycle that keeps on occurring unless you stop it. It's a cycle that keeps on occurring. That means to say, a mosquito bites you. That's where all the shit shat starts. Okay, you get the mosquito injecting sporozoites in you. It is these sporozoites that will get into the RBC and make schizons. The schizons will rupture and will make neurocytes. These neurocytes will again go inside and infect another cell, form another schizon. So what's going to happen is, it's going to keep on occurring till you stop it somewhere. It's going to keep on occurring till you stop it somewhere. So the cycle that comes from sporozoites that goes into a schizon, and from the schizon it goes into the rupture of the schizons. And the schizon means RBC basically. Neurozoites. From neurozoites again it gets into the body and a sporozoite again from the schizon. Unfortunately, we have to stop this somewhere. If you don't stop it, this will be an explosive kind of situation. It will be an explosive situation because more schizons, more merozoites, more trophozoites, more affection of the RBC, and eventually this patient will actually go down. So that comes to the question, how will this patient go down? Okay, so what's really occurring to this patient that this patient is developing all the manifestations you've kind of mentioned? Niharika, what do you feel? What's happening to these patients? So what is that causing? I mean, I understand. This is you all understand this cycle. But what's exactly happening here? Why is this patient going bad? What is in your mind? Niharika, what do you feel? Why this patient is going bad? She said about acute renal failure. She talked about patient getting altered mental status and patient getting convulsions. So what is happening here that this is occurring? Huh? That's anemia. I understand anemia, but what is the rest? What are all these things? So you have one part that is an inflammatory cascade that's forming. That's one other part. There is an inflammation that's occurring. That means to say, to be more specific, there is a large amount of cytokines, interleukins and all this getting released. TNF alpha and things like that, which is contributing to the inflammatory pathology that we see. Then
Rosette formation.
Yeah, so that's where you think about it. You start thinking this way, that this is inflammation ठीक है, that person all sepsis. But what are the affecting the area? That's why the path becomes so important. They form rosettes. What do you understand by that? So what's going to happen is there's going to be a parasitized RBC. That parasitized RBC develops knobs. They develop knobs. And when they develop knobs, what happens is other RBCs come and get attached to it, forming small rosettes. They are called as rosettes. And it is these rosettes that will actually cause a reduction of circulation into the various parts, including the brain. So in short, it's a microvascular obstruction that is going to occur in various parts of the body, including the brain most importantly, where there is a reduction in supply, thus causing raised ICP and things like that occurs in the brain. Clear? That is the pathology behind it, rosette formation. And that's probably the reason that sickle cell anemia patients don't get that much of malaria problem. Because they don't form those knobs in the first place. They don't form those attachment doesn't take place because their cell membrane itself is not okay. After all, the knobs will attach to a cell membrane. Their membrane is only not okay. So that's why they don't normally get malaria or sickle cell disease. Another thing that also occurs over here is because of the fact that this cell has got knobs, it deforms the RBC. It becomes less deformable. This rosette formation that it occurs. What happens usually in your brain is your RBC is squeezing to the smallest capillaries. They're squeezing to the smallest capillaries. And that's the reason that this deformability is so good that they move from one place to another place very easily, and that's why they're all alive here. Because what happens in a malaria patient is that deformability that you get is gone. So it goes and gets stuck rather than actually moving. So the RBC, which is supposed to carry oxygen, no longer does that. You understand it? It's not moving, it's not reaching the ends. You got the point. So when I again remember this thing, after the inflammation, the second thing is the rosette formation that we talked about. Along with the rosette formation, these knobs also are very simple to go and attach to the cell membranes. So there is cytoadherence. Okay, cytoadherence. And what does that do, cytoadherence? Why are you concerned about cytoadherence here? What happens? If it's cytoadherent, what happens? What happens if you have a bad RBC in your body? What happens if you have a cell that has eaten up the infected bacteria? What happens? Where does it go?
Spleen.
Goes to the spleen. It goes to the spleen, right? Since it goes to the spleen is responsible for breaking it down. And that's how the infection moves off. Now when there is cytoadherence, will this reach the spleen? That's where the problem comes. You understand? It's not reaching the spleen anymore because of cytoadherence. It's really not reaching the spleen anymore. You got the point. And since it's not reaching the spleen, these cells stuck up to the vessel wall are doing the same cycle. The asexual cycle is keeping on occurring there. New RBC getting involved, new knobs getting formed, new knobs getting attached to the cell wall or to the cell membranes or the vasculature, cytoadherence, which is preventing this from getting to the spleen. And that's probably the reason that these patients have a problem. Right? So rosette formation, cytoadherence. And the fourth thing is reduced deformability. There is a reduced deformability that occurs in these cases, and that's the reason that the vascular supply is not able to perform the function that it's usually supposed to perform. Clear on this? Yes. And that's why when you go back to her slide, go to the slide where you have that adjuvant therapies, they try to look at each of those parts. They try to look at each of those parts, of which, can you go down? This is yours. So she did mention a whole slide on adjuvant therapies. So if you look at those adjuvant therapies, you will realize that scientists have been trying to take care of all these things. The inflammation is known to cause ARDS. The inflammation, and we know that one way you can get down the inflammation is by giving an anti-inflammatory drug. Okay, so when you say steroids, that's where it comes in. You understand? That's where steroid comes in. They're thinking let's give steroids. Okay, but it didn't work. Unfortunately, It's because it's not just one mechanism. There are so many other mechanisms. So it didn't work. Okay. They decided to give anticonvulsants to everyone. It doesn't make a difference because it's a vascular problem. It's not something like it's lying over there. It's not like a mass that's lying over there. It's a vascular problem. So it didn't work. They decided to actually use pentoxifylline. Now what is pentoxifylline? It causes improved deformability of RBC. Okay. So now you try to use, when the RBC is less deformed, you try to use pentoxifylline. Less deformable, you start to use pentoxifylline. That's what you do when you have peripheral vascular disease from smoking origin. You know? So you try to give pentoxifylline. There it doesn't work because it's no other mechanisms. You got the point? So if you look at all of these, we started by saying there's a huge release of interleukins, cytokines, TNF alpha. So they started doing anti-TNF. You got the point? Then they said there's rosette formation and everything gets stuck to it, and platelets get stuck to all these things and rosette forms. So they decided to give and repair it. So, but unfortunately, none of them actually could actually be used as a routine therapy for severe malaria, because now we know there are too many mechanisms working. There are too many mechanisms. You understand it? So many mechanisms are working. How can it cure it? And that's why the first thing that I ask you when you have three things in your mind, what you should say is rapidly I want to treat it and diagnose it first. You understand? That's the reason that I told you what are the first three things that come to your mind. So my first thing would be rapid diagnosis. The second thing would be actually treatment as quickly as possible. And third thing would be watching for complications. If I would say these three things in my mind, I would be rapid diagnosis. The second thing would be rapid treatment. And the third thing would be watch for complications. You got the point? So now, why is this rapid diagnosis so important? You know, up to 2005, how it was endemic. It is endemic in many parts of the world. People die of malaria all over the world. Okay, huge amount of endemicity. Even 10 years ago, there were almost 100 countries who were actually told that they are endemic to malaria. For example, today, if somebody wants to come from outside to India, they have to take malaria prophylaxis. If they have to come from outside, as a resident from outside comes to India for tourism, they take malaria prophylaxis. They take doxycycline when they come in. And they take it for 4 weeks after leaving the country also. So that's the chemoprophylaxis. Somebody asked what's chemoprophylaxis. Is doxycycline started 2 weeks in advance, 2 days in advance, and then continued for 4 weeks after they leave the therapy. It is started at 2 days in advance, 100 milligrams twice a day. You continue for a month, and then 14 days later, after that, even for 4 weeks, you continue the doxycycline. That's one of the chemoprophylaxis that you would advise to anyone who comes in from outside. That's because India is endemic. Okay, now that's not wholly true. They consider it as endemic. There are parts of India that are endemic. We put it as. But for them, India is endemic because it's a tourist. Where is going to go with the So that's why they call it as endemic. Alright, but if you look at there are guidelines that come out every year from NCADVPC or what the National Vector Control Borne Diseases, something, where they actually label places in Maharashtra also as this is endemic, this endemic, this endemic, this endemic. Varje, some villages inside Maharashtra, their cities, 2 tiers are all called as endemic. Okay, so that is released on a regular basis. These are endemic. But on an average, we feel that we are endemic. Alright. So that's the reason that a while ago, in 2005, 2009, any fever with chills, you actually give anti-malaria. That was what WHO said. What WHO said was, any patient that comes in with fever with chills in an endemic area, you give them anti-malarials. You got the point? So everyone got a chloroquine. Fortunately, what happened after 2009? Chloroquine became resistant. Okay, we became extreme amount of resistance to chloroquine because this was what we were told to do. Not only us, Africa, where there's the African continent, among all the countries in Africa, almost 90% are actually having malaria. The African subcontinent. Okay. So what happens over there is any patient that comes with fever with chills gets an anti-malaria. You got the point? Everyone gets an anti-malaria. So why was that case? Because we didn't have a testing mechanism. So when you talked about a testing mechanism, the testing mechanism we talked about was, the first thing was microscopy. So when you say conventional microscopy, you need a person with a microscope. You need somebody who's skilled for that microscopy. You need somebody to prepare a slide with, and then have the patients to look at them. Right? So in an African country or an outstation, even if you go in India, in outskirts of Lateral, you will not get that. You will not get that. You go to the outskirts of this place, go to Palgar and outskirts of Palgar, you will not get it. Forget about Africa. You won't get it inside close to India also. That is the situation in our country. You are understanding? Not only in our country, in other countries also. Africa is exactly like that. Okay, that there is no one to read a film because it's not easy to read a film. There are two kinds of films. She mentioned a thick film and a thin film. So what is a thick film? What do you understand by a thick film?
So they take it on a slide and they try it and they put a stain, IMSA stain.
Yeah, so there are 3-4 states of which IMSA stain can be used. Yeah.
For 20 minutes, let it dry. Then.
But what do you understand clinically? I'm not saying the process. What is the difference with thick and thin?
Only parasite is there, malarial parasite is there or not, and which strain is there we...
Sorry?
Thin for species.
And thick
Thick is only to figure out whether there is a
Parasite.
And if you want to speciate them, thin. So that comes what is sensitive and what is specific. So the thick is very sensitive, whereas the thin is very specific. You understand? But at the end of the day, the parasite should be seen. That requires patience, skilled operators. So in the event that you have a patient fever which is in an endemic area and you have your direct microscopy to be negative, what do you do? What do you do? You are in an endemic area.
Continue.
You have a peripheral smear that you send, a thick and a thin smear. You found to be negative. What do you do? Because this is gold standard. So we repeat the thin smear again. That's why we need to do that. Because you don't have an RDT here in this endemic area wherever you are. So you'll have to repeat that again. Are you understanding the issue? So the issue is, I just can't rely on that because of the fact that it is operator dependent. It is dependent on the... 1 minute. Where were we?
Repeat this one.
If negative, then repeat the test.
If negative, you have to repeat. That's the point. The point is, if you are in an endemic area and you are in, say, the outskirts and you are a microbiologist, difficult. This was in 2009. So difficult. You understand? But that's what WHO, what they said, irrespective of what happens,
Give
you
it.
start the treatment. This is what WHO said. You understand the reason why I said that? Because now you understand the rapidity with which you should start treatment. You know that the treatment can become very difficult because of the fact that they go to multi-system organ insufficiency. And since the microscopy is something that is purely based on how you do it, so it can be negative. So that's why what did WHO say?
Start the treatment. Irrespective.
Yeah. 2010, what happened? Something very pathbreaking happened. Somewhere around that age. They came out with rapid diagnostics. So subsequently, WHO said, do not start treatment without rapid diagnostics. That's how WHO changed the guideline. You can imagine how the world is moving. It's not, and I'm not talking of 50 years ago, I'm talking 10 years ago. I'm talking 10 years ago. See how the world changes. Okay? You are a part of that history. So when you are going to take 20 years earlier, and 20 years later when you are talking to your students, you will tell them, हमारे time पे ऐसे करते थे sir. And then it has become like that. It's not very old, it's now 2010. So WHO came up with a guideline that don't treat unless there is rapid diagnostic test that is involved. So that comes to the question, what is this RDT? What is this RDT? When you said RDT, what did you understand? You heard Chalaka speak, right? Ashok, what did you understand by the rapid diagnostic test? So now you know what is direct microscopy.
Steady enriched
You
protein.
understand what is direct. So what is rapid diagnostic?
Steady enriched protein.
Ruchika, what do you understand by rapid? What comes to your mind? I mean, it's not an exam. What comes to your mind? When I say rapid diagnostics in malaria, what comes to your mind? You get it? You get the results sooner. That's what comes to your mind, rapid. It comes in sooner. So that's the first thing that comes to your mind, that if I have a rapid antigen, it should come immediately. So does it make any sense for you seeing a test of the INE when I call you up and ask you rapid antigen? Does it make any sense? Does it make any sense? So that's when I say, अरे यार तू क्या कर रहा है? I ask him, क्या कर रहा है? Because rapid diagnostic, this is COVID का swab test होता है. Now you know what is COVID. You've seen that small thing that comes in. You put one drop, or you touch that throat swab there, and put a drop over there, and then what happens if you get those two lines? Isn't it? Huh? It is exactly the same thing. It is exactly the same thing. It is exactly the same thing. You have a lateral flow immunochromatographic assay. It's called as lateral flow immunochromatographic assay. It's called that. You have a small thing where there is a small veil. You put a lytic agent along with it. So you take the blood, you put a drop, and then you put a lytic agent, which may or may not be there on the strip, or you might have to put it separately. It destroys the RBC. It lyses the RBC. So why you lyse out the RBC? What you want to see the schizons coming out. The schizons coming out. All these things. You see more of things. You'll amplify what's there inside the blood. Then it actually picks up an antibody. It picks up the. It attaches an antibody, and then if the antibody finds the antigen, it gives a color. That's why it's called immunochromatographic lateral flow assay. So I'll just repeat the whole thing once more. So it's very similar to your COVID test or pregnancy test. Have you seen the who is there? Nobody is married yet. So unless you have really seen pregnancy tests. So it's very similar to that. What you all are aware of COVID. So what happens in COVID? You put in a drop. Similarly, in this also you have a well. You have a strip. You have a control in a test. You put a drop. You put a lytic agent. It lyses. It releases the it releases the schizons. An antibody gets attached to it. There is an antibody not from the blood. Antibody that is there in that well. Okay, it gets attached to this particular thing. Once it gets attached to this particular thing, it starts moving slowly. It gets touched to the dye. And if the dye is positive, the antibody antigen reaction takes place. You get it to be positive.
Yeah.
Now there are a few limitations on this particular thing. It can't be always very simple. So first thing, we are benefited, and we must understand. With the presence of a rapid diagnostic kit, we are markedly benefited because the sensitivity of the kit is very, very high, especially to pick up falciparum malaria. And why are we worried about falciparum malaria?
More complications.
It's the more severe, not common, more severe.
Complication.
More complications, yeah. So it gives more complications. Falciparum, though we know Vivax also causes complications, but it is a falciparum that causes more complications than the Vivax. So does anything comes to your mind when I talk about RDT then? So A, that it is very sensitive to falciparum malaria, so it at least picks up my waste tissue here fast. It's not very sensitive to Vivax, though it is sensitive, but not extremely as much as falciparum. So the protein that it picks up from falciparum is, you just said it.
Histidine.
Sorry?
Histidine rich protein.
So it picks up a protein by the name of HRT2. Histidine rich protein 2 picks up this protein. This is the antigen that it is picking up. So what for Vivax then? That means if falciparum is negative, it is Vivax?
LDH.
Yeah, so it picks up an LDH for Vivax. It picks up an LDH, Plasmodium LDH. This is Plasmodium HRT2, this is Plasmodium LDH. So it picks up a Plasmodium LDH. Then what happens to malaria and ovarian? So we talked about Vivax, we talked about falciparum. What happens to malaria and ovarian? So there is a pan-plasmodium enzyme. It may be either aldolase or it might be LDH, which is pan, which is overall. So have you seen a test? What are we using in our hospital? In our hospital, what are we using? We are using Paramax. It's a kit called as Paramax. What happens in that kit is, it's a small kit just like how we have these wells. It's like that. It's called 1, 2, 3 lines in a well. Okay, and a control, yes, and a control also. The control also has to come. Okay, so the control lights up. If it is falciparum, then one of these lines where it's mentioned P falciparum or whatever, that lights up. That is, it's looking at HRP2. Okay, there is a second LDH. The LDH one lights up. It is Vivax. If both of them line up, it is both. Okay, and if these all don't light up, and this one lights up, this is the pan one, plasmodium. So you don't get ovarian or malaria written. You may get positive, but not virus or malaria, what you have to understand, this might be malaria ovale. If it comes, rapid diagnostics is positive, but they are not giving you whether it's falciparum or vivax, what does it mean? It's either malaria or ovale or some other plasmodium. Knowledge C, which will never come to India. It's monkeys.
Knowledge C.
But do not take care of it. But humans we call about malaria and ovale.
Oh, well.
It's important for you to understand that, right? So when the rapid diagnostic comes, you should ask them, what is it, malaria or virus? If it doesn't come, what do you do next? You take another peripheral smear, look at it again. There's no other way to do it. If it doesn't come positive, it comes as others positive, not malaria, not vivax, not falciparum and not vivax. What do you do? Send another thin smear. Because I need to know the species. Species becomes important for me.
Sir, sir, in the some people advise if the reports are coming negative but clinically they are suspecting malaria, during febrile phase they advise you take the blood during that febrile phase patient having.
So that might work with peripheral smears,
Yeah.
because of the fact that we normally are thinking, thinking, I mean it's a hypothesis that the febrile phase is coming in because there's been a rupture of the schizon. That is the thinking, but it has never been proven like
Yeah.
that. It's never been proven like that. But these are all methods that were done when we didn't have RDTs. But with the advent of RDTs, we are in a different league now. हम लोगों को ज़्यादा time लगता नहीं है. You understand? We get the reports immediately. All these things become very easy for us because to figure out in microscopy, you need to have this competency. But importantly, you can pick up even lesser number of parasites compared to the RDT. That comes as a limitation. So if you have an RDT, it has to have at least 200 parasites per microliters. You understand? Whereas if you have a just thin or a thick film microscopy, you require not more than 50. In 50 you will get it. Are you understanding? So rapid diagnostics is not that it's very clear. It's only this way that the parasite density has to be somewhere around 200. We have 10,000 parasites. It's not that 200 is less. It's not 200. Huge density. 200 is not less. But I'm just telling you, head to head, you may pick up much more in a microscopy versus RT. That's why now the standard of care is RT, rapid diagnostics. Are there other methods? Yes, there are other methods, but not validated as such. A PCR, a multiplex PCR. What is a PCR? You take a gene, you amplify it, and then you read it up in a multiplex PCR like BioFire. That's a PCR. So there are other tests where you can detect malaria from the PCR, but of course not validated, not something required. The advent of RDT, why do you want to do a PCR? You understand? Another problem with the RDT is that, say you had a falciparum a while ago, you treated it, it can still be positive for a while. Are you understanding? Because it's after an antigen. So, like the PCR, if you were to take your rapid diagnostic test, just thrombocytopenia, they give an RDT, they are positive again. This is the usual thing. What happens is, you see a patient that comes to the ICU for some real reason, and because of your poor diagnostic and clinical skills, you send out number of investigations, of which one is rapid malaria. It comes out to be positive because you had a thrombocytopenia, you sent it. The patient has no clinical feature at all, absolutely no clinical feature at all of malaria. And you go and start treating that malaria with artesunate and quinine and stuff like that. Because RDT can be positive, but that's not the clinical CP. You could have had some 10 days ago. He's out of that. This is something else. Are you understanding? So you must use it in the clinical context. That's why the classical patient has to be the patient who's manifesting clinical signs that you explained. Fever, chills, frustration, not feeling okay, abdominal pain, things like that. You should have those features in place before you send. You just don't see a thrombocytopenia and send off your, which is a very long practice that all of us feel. That's why when I asked you what comes to your mind in the first place, you said thrombocytopenia. When I asked you what comes in your mind, all of people said thrombocytopenia. You shouldn't think like that, because then what will happen is, the moment you think thrombocytopenia, the first thing will be send rapid diagnostics for malaria. Because clinically you have to work. You have to understand the clinical species basically. Patient just has thrombocytopenia, does not fever, doesn't feel anything. Is that malaria? It's not malaria at home. Malaria will come with fever. You imagine a schizon rupturing into the blood has to react now. It has to react. The blood has to react. It has to cause some fever. If it's not causing fever, you just send the rapid malaria because you saw thrombocyte become positive. You start treating it and you forget the real pathology, which may be malignancy for that matter. You understand? Huh? So you must send tests with the thinking that what I'm expecting. Not I'm going to send some tests because something will come positive. So that is the wrong practice in critical care where you pan tests you do and you figure out something coming positive. It's very wrong to do that. Very rarely we do that. We don't want to do that. It just indicates your non-clinical acumen, basically, not a clinical acumen. Okay, this happens many times. Patient is there, so urine culture, blood culture, what nonsense is this? I mean, what utter nonsense is this? You send out everything and उसमें से कुछ आ गया और उसको फिर treat करने चालू कर देंगे. It doesn't make any sense at all because it's not going to work like that. It's not going to work like that. Okay. So this comes to now we got the rapidity of diagnosis. We've understood why it's important. We know the two tests that we're going to use. Comes to my question as to what should we be treating this patient with. So now that we rapidly have diagnosed it, my second question in my mind was I want to rapidly treat it. So and I want to rapidly treat it because this patient has come to the ICU. There would be some reason to come to the ICU. The reason has to be that he's complicated. That's why he's come to the ICU. So what would be my treatment? First go if I tell you, and why? So Shalaka took the talk. Elizabeth, what do you feel? The question is, patient has come to the ICU. I want to rapidly treat it. What do I give? I want to rapidly treat it. We just explained. We want to treat it rapidly, isn't it? Because I'm certain that if I don't treat it rapidly, by one complication, second complication, third complication, DIC, death, and things like that, what do I treat it? IV, artesunate, why is that so? And how much will you want to give? Okay. So why artesunate? Artesunate, see, we have a very nihilistic attitude. We have to COVID to Chinese medicine. Okay, something I don't like is Chinese medicine nowadays because of COVID, because they walk in our lives. China basically came from there. I just don't mention. Okay. But this medicine is one of the biggest things that China gave to the world. Artemisinin. Okay, Artemisinin is one of the biggest things that it gave to the world, isn't it? Huh? And this comes from a herb called as Artemisinin annua. That is the name of the herb. It's a shrub from where you make that medicine. Artemisinin annua it's called. Huh? It's a shrub from where this particular artemisinin has come out. Okay. So initially this was oil-based medicine. So it was very difficult to give it IV. So they used to give it there on iron in China. Then later on people started working on it and they made it water-based and could be actually given in IV forms. And that's why we call it the new artesunate that we have. Okay, you know the food failures now. Artesunate. Right? Huh? This they have been using for ages. Only we don't take Chinese medicine. You don't see Lancet with China ka papers. Any gym with China ka papers they need there. Because they don't want to take their papers. For some reason they have got that keep them away attitude. That's why we don't see Chinese medicine coming in papers. We don't see them coming in Lancet. We don't see them coming imports that we got from China, isn't it? So how did it come? So what happened is there was a trial that was conducted. It was called as the sequence that he mentioned. Southeastern quinine versus artesunated malarial anti-malarial treatment. That was the full form. Sequemat. Southeast Asian quinine versus artesunate treatment for the treatment of malaria treatment. Sequemat. Okay. What did they do here? They looked at 1600, 1400 some odd patients. They looked at. Okay. They were 100 patients they looked at. So what did they do? They gave a group of patients quinine, another group of patients artesunate with what we talked about. Okay. Now, why is this problem with quinine? Have you used quinine any time? So, if you use quinine, what is the problem? How do you use quinine? Anyone use quinine here? Anybody has used quinine here? No one. No. Quinine? Anybody use quinine here? No. So,
Tinnitus.
quinine you can use now also because it is still stage 1 recommendation. You can still use it. I mean, it's not this way that you can't use it. You can use it. But quinine has got its problems. Now, its problems starts with immediate problems of arrhythmia. You have tremendous QT prolongation. So, it first of all needs to be loaded. It has to be given loaded, so it will take some time before it achieves levels, which is not the case with artesunate. Okay, it is given immediately, it works immediately, artesunate. Whereas this has to be loaded. Some 3-4 hours loading जाता है उसका. In that 3-4 hours loading, you're taking some 10 ECGs. 5-6 ECGs you take because these QTs keep prolonging and problems keep occurring there. The second thing you get is a gross hypoglycemia. So you put these patients in a 25% dextrose and you give it. You're putting this quinine in dextrose and giving it. Because what happens is there is a tremendous hypoglycemia that occurs with quinine. Okay, it's very difficult to manage these patients. So the side effect profile of quinine is much higher, immediate as well as late. Synchronism is something that comes later on, which is hearing loss and stuff like that, which occurs on a later date. Okay, but the more important side effects are these two. Okay, that is the arrhythmia potential and the hypoglycemia potential, which is quite alarming. You understand? You start wondering whether the arrhythmia is coming from quinine or it's coming from the patient's special condition, or the hypoglycemia is coming because the liver is inflamed or rather than the quinine. So it's a diagnostic element when you get quinine in place. So it's a problem drug. It's something that I would probably don't want to use. Okay, so that's why they tried trial artisan, which is conventionally very, very safe. How does it work? It probably works on the free oxygen radicals, so the inflammatory pathway takes care of. And then it also targets the plasmodium itself. It is supposed to work on the sarcoplasmic endoplasmic reticulum, SERCA, calcium. Okay, it's called SERCA activity, SERCA. Okay, it works on the SERCA of this plasmodium, and plasmodium goes off. So obviously it's something that we have a proposed mechanism of action. Of course, it's not something that is 100% proven, but this is the proposed mechanism of action. So now you have a drug that's working on the plasmodium. Okay, at the same time, it is not that toxic. Now, and the third most important thing that one of the most important things that you also have is it works on a large number of cells, not only the one life cycle phase. It may work in gametocytes, it may work in Schizont phase, it may work in the merostrophocyte phase, which is not the case when we look at quinine. It works only in the erythrocytic phase. You understand? It will work only in the erythrocyte. It doesn't work in the ring forms and all those things. It doesn't work. No, that comes to the question that when you do a peripheral smear and someone calls you and says this gametocytes, what's your thinking? In the peripheral smear, it says there was a post-malarial pathogen. What's the next question? When you say peripheral smear is post-malarial, what's the next question that you'll ask? I mean, why I'm asking this question? Because this is a question that I want you to ask.
How many parasites?
Percentage of
Why? So Shalaka is giving a thing that what is a. So you're basically trying to talk about parasitic index. Right? This is what you're talking about. So you're talking about parasitic index. Why? You may want to judge the severity, but it is not said that the severity would change. There was a way to do parasitic index because it was more than 20 in plasmodium falciparum. That was a trial part for exchange transfusion. So when there were trials of exchange transfusion, if the parasitic index was more than 20, there was a whole group of people doing. Even I have done exchange transfusion for plasmodium falciparum. Okay, that was if the parasite index was more than 20. But now we know it's not really relating to that. It's not relating, and we know that now at the moment the WHO doesn't really recommend exchange transfusion. Doesn't recommend it. Would I do it? I may still do it. I may still do it because if the patient is not improving, parasitic index is not coming down, then I still may probably try to do a exchange transfusion. I'm telling you now. But there's a very small subgroup of patients where I might attempt it. Though the WHO does not recommend it because it may itself cause hypotension and all these things. Right? So what's the peripheral smear? What do you say? Ask me. Among this phase, which is the most dangerous phase you feel? So you took pathophysiology, Sachin. What do you feel if you see will be more disastrous? So you have sporozoites, you have neurozoites, you have schizonts, you have gametocytes at the asexual phase. It goes to the musculoskeletal and gametocyte. So you have gametocyte, you have merozoite, you have sporozoite, you have trophozoite, and you have schizont. What do you think would be something that if the peripheral smear shows me, I have to be very scared? Gametocyte is going to be there at the end, After all the RBC is gone, then the gametocyte comes because it is a part, it is just going to be taken by the mosquito. It is not going to do anything to us. You understand? What is the gametocyte for? For the sexual phase of the mosquito. Next cycle, मतलब वो gametocyte खाएगा, फिर वो जाएगा अपने body में बनाएगा. You got the point? So it is not going to cause anything to us. It may prevent transmission. I mean, if you take a gametocyte and you give a drug, it may prevent transmission from say Chandrima to Niharika. But otherwise, to you it is going to cause anything? No. So, what is important? Which one? Merozoites. Merozoites are very young phases.
Schizons.
Merozoites कहाँ से आ रहा है? Merozoites are coming after the schizons is ruptured. It is the schizon. Because what happens is the schizons are going to rupture. They are going to release many merozoites. They are the ones that are going to cause this entire thing that we see over here. You understand? So if I do a peripheral smear and they say that there are schizons I'm seeing, I'm worried. If they say there are ring trophozoites, I'm okay. If they say there are ring stages I'm seeing, I'm okay. If there's gametocytes, I'm really okay. You understand? So when a peripheral smear comes in, it's important for you to and you'll understand this only if you know the pathophysiology. If you understand this only if you know the pathophysiology. That's why pathophysiology becomes the background of everything, right? Malaria, right from start to the end. I've been talking about pathophysiology, isn't it? That's why the pathophysiology becomes very important. Only that single cycle explains to you half your problems. So I am worried about the fact that there are schizons. Because there is a possibility that a rupture, merozoites will release and then that will populate more. The cycle will keep on happening. But if they call me, if they say I am seeing ring forms or I am seeing gametocytes, I'm okay. I know this is something that I can easily take care of. You're understanding? Clear on this? That's the importance of peripheral smear. So that comes back to the question, what does Sequomat do? So Sequomat, what it did was, they looked at these cases and they said, surprisingly, out of 1400 patients or something, 1400 odd patients, only 140 were from India in that particular trial. Can you believe it? You record the number? Can you believe it? I mean, I would have thought, if I would have thought in the background, 1400 patients, 1000 हमारे इसमें से आना चाहिए. बराबर ना? So that is why for us that trial is not very important because Indian population was only 140. So if tomorrow somebody tells me that 100% artemisinin is better proven on an evidence-based perspective, I can't say yes to that, no, because Indian population is only 140 million. Okay, but then we follow what our trials have shown us problematic. So what does the Sequomat say? The Sequomat did. What did they find out in Sequomat? What did they find in Sequomat?
Mortality benefit and
Yes, ma'am. They found almost a 30 to 40% improvement in mortality when they used actually Sequomat as compared to quinine. So then you can't take that away from them that artesunate was something that really changed mortality in a large group of patients. Second thing, it actually improved recrudescence from fever. Fever came off much faster, indicating what? It's stopping this cycle, isn't it? And the third thing is the parasitic phase, which they were actually making a clearance of parasites, that was also very high. So since you had a clearance of parasite, since the fever recrudescence was occurring, and there was a mortality benefit significant, we can't disregard all that. So that is why we have now gone into the use of artesunate, which is a drug which is proven also in pregnancy.